Hello everyone, we continued with kidney disorders and starting with acute kidney injury. We started with continuing it and the respiratory staging and stage risk injury, failure, loss, and end-stage renal disease classification. Its risk decreased by 22%, clearance will be decreased, and urine will be less than 0.5 ml per kg per hour for 8 hours. Injury to the kidney when creatinine clearance is decreased by 50% and less than 0.5 ml per kg per hour for 16 hours. Failure fully decreased by 75 or less than 35 ml per minute for 1.73 meters square or less than 0.3 per ml kg per hour for 24 hours or anemic for 12 hours. Loss of kidney function, persistent renal failure for more than 4 weeks, not applicable clearance stage, persistent renal failure for more than 3 months. And this is the key group. Kidney disease, including blood outcomes, classification systems, serum creatinine, stage 1 is increased 1.5, 1.9, stage 9, or increase more than or equal to 27 micromole per liter, urinary plus less than 0.5 per kg per hour, per kg per hour. Stage 2 is increased 3 to 2.5 into baseline and less than 0.5 or more than 12 hours. Stage 3 increase 3 times the baseline, oxygen taken more than equal to 354 micromole, or initiation of RT and estimated GFR is less than 35 ml per minute for 1.73. Stage 3 is less than 0.5 ml per kg or unit for more than 12 hours. This is some metabolic abnormalities, renal failure, acute renal failure, and then therapies. Metabolic acidosis, soda bicarb, and hyperphosphatemia, calcium carbonate, dietary restrictions, and hyperkalemia, calcium gluconate PCG changes, and salbutamol nebulized with IV, and dietary restrictions, calcium exchange resin, glucose and insulin diffusion, renal replacement therapy. And causes acute kidney injury, pre-renal and renal and post-renal. In pre-renal, hypovolemia, gastroenteritis, burns, sepsis, hemorrhage, nephrotic syndrome, and circulatory failure and heart failure. In renal vascular hemolytic uremic syndrome, either HUS, vasculitis, ambulance, renal vein thrombosis, tubular is acute tubular necrosis, ischemia, toxic and obstructive and glomerular nephritis, and interstitial nephritis and pyelonephritis, post-renal is obstruction, and congenital posterior walls are required, blocked urinary catheter, renal and aortic stones. Posterior just requires assessment of the site of obstruction, relief by nephrostomy or bladder catheterization. Surgery can be performed once fluid volume and electrolyte abnormalities have been corrected. Renal replacement therapy in acute kidney injury is indicated when there is failure of conservative management, hypokalemia, severe hypernatremia, pulmonary edema, or severe hypertension due to volume overload, severe metabolic acidosis, multisystem failure, peritoneal, multisystem failure, peritoneal dialysis, and hemodialysis can be undertaken for acute kidney injury. However, the child requires anatomy such as a heart failure, continuous venous hemofiltration, provide gentle continuous dialysis absolutely no. Acute kidney injury in childhood generally carries a good prognosis for recovery and less complicated for life-threatening conditions. Severe sepsis following cardiac surgery or multisystem failure. These are pre-renal, most common cause in children from hypovolemic circulatory failure, renal most often HUS or multisystem failure. Renal portion is from renal obstruction. And there's most three underlying cause metabolic abnormality, renal replacement if necessary. Hemolytic failure, suicide side of acute renal failure, macroangiopathic hemolytic anemia, and thrombocytopenia. Typical HUS is secondary to GI infection with cytotoxin, producing E. coli O1.7, H7 acquired through contact with farm animals or eating uncooked beef or less often shigella. It follows a prodrome like diarrhea toxin from these glands enter the GI mucosa and preferentially localized to natural cells of kidney where it causes intravascular thrombogenesis. The coagulation cascade is activated clotting is normal. Unlike in disseminated intravascular coagulation, treatise are consumed in this process in microangiopathic hemolytic anemia, low serum hemoglobin, high serum lactate dehydrogenase results from damage to red blood cells as it circulates through the microcirculation, which is included. Other organs such as brain, pancreas, and heart can also be involved. With early supportive therapy, including dialysis, typical diarrhea-associated HUS usually has a good prognosis, although long-term follow-up is necessary as there may be persistent proteinuria and the development of hypertension and progressive chronic kidney disease. By contrast, atypical HUS has no diarrheal prodrome, may be genetic, and may relapse frequently. A monoclonal anti-terminal complement complex antibody, infliximab, has really improved the prognosis of this condition. Frequency has a high risk of hypertension, progressive chronic kidney disease, and mortality. However, it is very expensive. The duration of treatment is unknown. Hemolytic renal syndrome side is AKI, hemolytic anemia, and thrombocytopenia. Chronic kidney disease is progressive loss of renal function due to numerous conditions. Has 5 stages shown in table. Stage 5 chronic kidney disease when GFR less than 15 ml per minute per 1.73 is much less common in children than in adults. We can consider only 10 per million of the child population. Each year, congenital pulmonary causes are more common in childhood than are required. And breeding severity chronic kidney disease is estimated GFR is stage 1 more than 90 ml per minute and 1.73, which is square, and normal renal function structure normality or persistent hematuria or proteinuria. Second stage 60 to 90, 89 ml per minute per 1.73 meter square and mildly reduced function asymptomatic. And 30 to 50, stage 3, moderately reduced renal function with dystrophy. 15 to 29 ml per minute is stage 4, severely reduced renal function with metabolic derangements and anemia. Need to make fast therapy. And 5 is less than 15 ml per minute and stage 5 is therapy. Right, and causes of chronic kidney disease causes are congenital anomaly of kidney and urinary tract that's 53% in children, glomerular disease 19%, familial heredity is 13%, systemic diseases affecting kidneys is 4%, tubular interstitial diseases, miscellaneous renal diseases, PKD, metabolic, etc. And genetic fistula chronic kidney disease presents with anorexia, lethargy, polydipsia, and polyuria. Faltering growth, growth failure, bony deformities, vomiting, dystrophy, renal rickets, hypertension, acute on chronic renal failure, precipitated by infection or dehydration, incidental, finding of proteinuria, unexplained normochromic, normocytic anemia. Many children with chronic kidney disease have had the renal disease detected before birth by antenatal ultrasound or have previously identified renal disease. Symptoms really develop before renal function falls to less than 1/3 of normal or chronic kidney disease stage 4. Management aims of management are to prevent the symptoms and metabolic abnormalities of chronic kidney disease to allow normal growth and development and to preserve residual renal function. Management of these children should be conducted in a specialized pediatric nephrology center. Nutrition, poor appetite, nausea, vomiting, common improving nutrition using calorie supplements and nasogastric or gastrostomy feeding may be necessary to optimize food. Protein intake should not be restricted and instead needs to be sufficient to maintain growth and a normal abdomen. Food containing potassium phosphate needs restriction under the guidance of pediatric renal dietitian. Prevention of renal dystrophy, phosphate retention, and hypercalcemia due to decreased activation of vitamin D leads to secondary hyperparathyroidism, which results in osteitis, fibrosis, and osteomalacia of the bones. Phosphate restriction by decreasing the dietary intake of milk products, such as garlic, has a continuous short and balance in the solution. Many children with chronic kidney disease caused by congenital structural malformation, renal dysplasia have an obligatory loss salt and water. They need salt supplements and free access to water. And other causes of chronic kidney disease, such as steroid resistant nephrotic syndrome, or if the patient is anaphylaxis, Fluid and clot resection very importantly when fluid oral hypertension from edema. Treatment with BiGAP supplements necessary treatment acidosis. Anemia reduced production of erythropoietin and circulation of metabolites that are toxic to the bone marrow results in anemia. This responds well to the administration of the recombinant human erythropoietin, which is administered subcutaneously. Hormonal abnormalities. Many hormonal abnormalities occur in progressive chronic kidney disease. More importantly, there is both hormone resistant with high growth hormone levels, but the growth recombinant human growth hormone has been shown to be effective in improving growth for up to 5 years of treatment. Whether it improves final height remains unknown. Many children with stage 4 and stage 5 chronic kidney disease have delayed puberty and a subnormal pubertal growth. With dialysis transplantation, it is not now possible for all children to enter renal replacement therapy programs when stage 5 chronic disease reach optimal management by renal transplantation. Technically, this is difficult in very small children. Minimum weight 10 kg needs to be reached before transplantation to avoid renal vein thrombosis. Kidneys obtained from living-related donors have a high success rate than deceased donor kidneys which are matched as far as possible to the recipient HLA. Universal interesting type. Patient survival is high, and first year graft survival is around 97% for living related and 96 for deceased kidneys in the UK. Graft losses from both acute and chronic rejection of recurrent disease mean that 5-year graft survival is reduced to 89% for living related kidneys, 86% for disease donor kidney transplant. Some children need retransplantation. Current immunosuppression is mainly the combination of tacrolimus and mycophenolate, mofetil, and prednisolone, and there is increasing use of minimal steroid regimens which improve growth. Ideally, a child should receive transplant before dialysis is required, but if this is not possible, repeated dialysis may be necessary. Peritoneal dialysis, either by cycling overnight using machine continuous cycling peritoneal dialysis or by manual exchange over 24 hours continuous ambulatory peritoneal dialysis can be done by the parents at home and is therefore less disruptive to family life and the child's schooling. Hemodialysis alternative and has been usually done in hospital 3 to 4 times a week, although pediatric home hemodialysis is increasingly adopted and improves quality of life in adults. Chronic kidney disease causes congenital structural malformation of hereditary nephropathies. Most common presentation normal antenatal ultrasound, anorexia, lethargy, polydipsia and polyuria, fault in growth, growth failure, renal decay, osteodystrophy, hypertension, proteinuria, anemia. Management, nutrition, and gastric or gastrostomy, feeding, phosphate restriction, activated vitamin D to prevent renal osteodystrophy, salt supplements and free access to water to control salt and water balance, bicarb supplements to prevent acidosis, erythropoietin to prevent anemia, growth hormone, and dialysis and transplantations. The only left is case history. Kiran was born with a severe form of posterior which was an chronic kidney disease from birth. He was managed for the first 3 years with intensive nutrition input. He underwent treatments for UTIs, received medications, including salt supplements, which reporting needed to have his bladder augmented and went on to dialysis briefly. Before he had a life-related transplant from his father at the age of 4 years, he is now growing and developing well, although he continues to use immunosuppressants and occasionally suffers from UTIs. No tips for UK. So this is the end of kidney disorders. We will do clinical cases now. Okay, let's start that. Thank you very much.